So the reason why we got into the care transitions, or KC3T, is welcome to Kentucky. Unfortunately, we glow red for everything that is bad that you can have. And we usually have multiple of these. So unfortunately, in this particular scale, the higher you are, the worse you are. So we are right up there towards the top for diabetes, high blood pressure, obesity, heart disease, hospital readmissions. We're #1 in that. And when you're looking at cancer, we have the highest incidence of cancer in the United States, especially lung cancer. So these are some of the issues that we're dealing with. And this is the population that we've been working with, especially in the area of stroke. And when you're talking about stroke in Kentucky, we're part of the stroke belt. We're some of the worst of the worst. Central Appalachia is the highest incidence of stroke in the United States. And when you're talking 24,000 cases in 2013, that is a huge number of stroke each year that we're having to deal with. That's part of why we've developed our stroke registry as well. And when you're talking about the huge impact on the healthcare system of over $950 million on the healthcare system, something needs to occur. And we also know this from working with our individuals who have had stroke. We also know that there is a huge readmission rate. So someone has a stroke, the chances of them being readmitted is relatively high within that first month to 3 months, but especially a year out, the data is showing up to 30% of individuals who have a stroke are going to be back in the hospital for some reason. We also have a huge number of them that use the ERs as their primary care physicians. And they just show up time and time again, which from a healthcare point of view, that is the most costly form of healthcare you can provide, is your ER, instead of going to the primary care physicians. So looking through all of this data and working with our partnerships, we have developed and know that there is a need for follow-up education. We know that from the clinical point of view because I know when I used to do rehab over at Cardinal Hill on the spinal cord unit and brain injury unit and stroke unit for a while, they don't remember half of what I taught them when they were in inpatient rehab. They were too busy trying to deal with the fact that their life changed. They want to go home. They're separated from their family. And it's only when they get back home that they realize, what was I taught? Where is it? And that's where it falls off the map. That's where they don't have that follow-up education. So we know, we've known that one for multiple years now, and the other studies we have done have shown it, that we need to do follow-up. Especially when you're looking at that big list that I had showed of the Kentucky Uglies. Those are all the comorbidities that lead to stroke. So if I've had someone who's had stroke, guess what? They're going to have some of those issues here. So we have to do the chronic disease management side of it. The care transitions is a big thing, is when people go back home, no one handed them off. They just were sent back home. What do they do when they go back home? The typical kind of follow-up is if they're leaving from a Cardinal Hill going back home, is you'll have a caseworker who will make a phone call once or twice. How are you doing? They're 2 hours away. That's not helping someone transition back in their home. So we need to have some sort of service that will help literally transition them back. How do we improve medication tracking? Because we know individuals with neurologic condition, our spinal cord injury, out of the 3 groups, spinal cord injury has the highest number of medications that they take. Another professor and I did a study several years ago where we were tracking from a very huge national database the number of medications on average individuals with spinal cord injury were taking. It was monstrous. I mean, we were looking at polypharmacy, so more than 5 medications at the same time. 85% of the population of over 12,000 people were on 5 or more medications. We had over 50% of them were on 10 or more. We had people who were on 17 medications at the same time, and they're all hardcore pain medications, antispastic, antidepressants, all ones from a neurophysiology point of view know they're beating up your nervous system. So, you know, tracking medications. And we also know that when you have multiple physicians, One person will put you on one thing. You go to a different doctor who doesn't do your, what medications are you on, they put you on a different one. So you have someone who are on 2 different opioids at the same time. Okay, no, we've had people on 4 opioids at the same time. Different names, so they thought that they were just, oh, that's my leg medications. Oh, that's my back medications. It's like, those are all opioids you're taking there. So how do we track what they're doing? And how do we improve communication? How do we get them the essential assistive technology, the medical equipment they need? Just because you have insurance doesn't mean you can actually get hold of the medical equipment. You can't afford to copay. And how do we advocate in the underserved populations? So through all of this, about 3.5 years ago, we developed what we called the Kentucky Care Coordination for Community Transitions Program. This started off as a small pilot study funded through our Center for Clinical and Translational Science here at UK, the CCTS, did this pilot study. Since then, we have actually expanded out, and this is actual service program that serves Southeast Kentucky. The whole goal is, can we provide you the needed resources on all the different levels to advocate for you? Can we improve quality of life, community integration by decreasing your barriers to getting your health care, to getting your medications through the waiver systems, getting the equipment you need, and anything else you? Can we jump into that gap of when someone is discharged home to the time they get their Medicare sometimes is 1, 2, 3 months that they're sitting home without any services? Well, guess what? From a rehab point of view, within 3 months, any gains I got on inpatient rehab can be gone. And you're starting from square one before they even got the resources they need. Can we completely eliminate that gap? Is the purpose of this particular program. So what are the services that we provide here? We enroll people in their health care. That since we've done so much enrollment the last 2 years, this is not one of our major areas anymore because most people have some sort of insurance. But Connect, even if you know what you're doing, it was really, really hard to work your way through that system.
And it's going to be worse again now.
And it's going to be worse. So now we're bracing for what's going to happen. And we know this is now about to become a major source of what we need to be able to do. Can we help assist in accessing medications, obtaining their follow-up care? Can we make sure they get to their doctor's appointments, get their follow-up rehab? And can we make sure that those doctors are actually talking together?
And have primary care. And how many of your people had no
primary care? They were using the ER. So can we get them to ER, get them out of the ER? Can we get everyone talking together? Can we provide the follow-up education? That's what we do, is we go in and we have a very specialized trained community health worker with a lot of training in chronic disease management. I'll talk about that in a second. We bridge that communication across the healthcare system. The one thing I want everyone to know, and whenever I do this talk, and like when I was presenting this yesterday to the directors of the hospitals down in the south central part of the town, is we don't work in isolation. There's too many programs where, oh, we get a referral and then they do their little thing and that's it. You never hear about them. We are constantly working back and forth with the care team. In fact, this is based down in Hazard, right next to ARH Hazard, which is one of our primary teams, which is the primary rehab facility for stroke in the region. Our community health worker is actually part of the discharge team. That's how linked in we are. We catch the people before they leave, and we are constantly talking back and forth to make that seamless connection. And I'm going to talk to a little bit about our stroke caregiver support group, which is a neat team. We had our last meeting on Wednesday. So we use community health worker. Her name is Keisha Hudson. We're hoping we're going to be able to clone her many, many times across Kentucky because she is a force of nature. She is from Eastern Kentucky. She's down from down in the Perry County area. When you're looking at navigation, this is becoming a very, very tricky subject, especially for payment through Medicare and everything else. is what is a navigator? Do they need to be a professional? Do they need to be a nurse, which is historically one of the models? Another model is a PTOT. Or can it be someone who is a lay health navigator? Can they provide as clean resources? And when you look at the majority of what we do, you don't need a trained nurse to do it. You don't need a PT to do it.
And cost is an issue.
And cost, and so when you use those other models, they're very, very expensive to run. Ours, since we use a community worker, it's half the price to run it. Okay, but she has received the training through Kentucky Homeplace, which is actually it's an internationally known community health worker program. Fran Feltner has run it. I mean, she travels all over the country, all over the world, presenting on it because it is a model system of how do you provide services within the community.
And with lay.
And with lay people. So people from the community that know the lay of the land. So we know where to track down the Miss June from the First Baptist Church. Okay, but I have provided her a lot of follow-up education in the area of stroke. So she knows stroke process, stroke development, but she also has training, and she's actually to the point where she is a trainer in chronic disease management. She can train other professionals, and it's through the Stanford University's chronic disease management program and diabetes management program. So through Stanford University, she is trained to do all of this follow-up education. Okay. Another thing that makes our program different is exactly how hands-on we are. Many of these other programs, you'll follow the person for a month, you'll do 3 phone calls. We are in contact with the person a minimum of 1 time every single week for the first 3 months. Many times it's much more than that. Very, very labor intensive, and our people need a lot of help those first 3 months. Between 3 and 6 months, it's every other week, and then hopefully we can wean you out of the program at about the 6-month mark. But a lot of data from what we have done, plus other studies said, you really do need to follow these people at least 6 months out, because a lot of things are happening from a physiologic point of view and from family caregiver point of view that you need to be able to step in there and provide that support, especially between 3 and 6 months. That's when things start to fall apart on people and the family units. So a lot of hands-on. If you were using a nurse or a PT/OT, you could not sustain this. But by using a local health worker, we can. Okay. So when you look at the population here, we track a huge amount of data, which Tony is doing some studies for us, doing some comparison studies. But when you look at our numbers of all the comorbidities we track, there over 75 or 70% of our individuals have at least 5 of these comorbidities. So they're diabetic, hypertensive, smoking, obese, hyperlipidemia, or combinations there. We have quite a few of them that have pretty much all of them. These are really sick people that you're working with. That's the challenge, is you send them back home, they've had the stroke, you overlaid the stroke on these conditions that caused the stroke, and now you have to manage them. And you have to teach them how to self-manage. That is where we're currently working in that element, really teaching that self-management and teaching caregivers self-management. Okay. When you look at what she does from day to day, the majority of what she does is providing follow-up education. A lot of the chronic disease management. How do you manage your diabetes? Diabetes is huge for us. How do you manage your hypertension? Okay, what is the stroke process? So they have a better understanding. They go home and they still don't really understand what happened to them. And the interesting thing is, because there are so many cases of stroke here in Kentucky, that it's actually become so common out there that they don't think about it. Everybody knows several people in their family that have had a stroke.
So it's kind of natural.
It's just natural. Oh yeah, they had a stroke, just like my aunt and my husband and all this. So it's a different perspective from them, that they're going, oh yeah, or I've got sugar blood. You got diabetes. And how do we manage that? medical management programs. We do a lot of follow-up with the discharge plan. So your rehab team says, you must do these follow-up exercises, you must do X, Y, and Z. We track that. We track compliance and adherence rates. Okay. Okay. So when you look at two of the big ticket things from the healthcare side, ER visits. Over 3.5 years, we have 0 ER visits from our folks, because we get them to the doctors they need to go to. They're not using the ER as their primary care. Okay. Compared to, we have a comparator group out there. These are the individuals over the last year who chose not to come into our program, but they're from the same hospital, go back to the same region. When you look at those folks, over 80% of them are still using the ER. Many of them used it multiple times within 30 days of going home. Okay, so that is meaning we're getting our people to where they need to go for their care, but it's also the huge savings on the healthcare side of it. And in 3.5 years, we've had one 30-day readmit, and it had nothing to do with stroke. Actually, technically, we have 2, but the first one didn't count because it was our first visit, and when Keisha went into their home, found this person in a diabetic coma. And the healthcare provider didn't know what to do. So we worked with them. We got EMS out there, and that person got different care. So that one we don't count because we didn't even, but I'm glad Keisha was there. Yeah. The second one was the individual, while Keisha was there, asked about having her observe a surgical scar because they had another procedure. And when Keisha had looked at it, she goes, that's very, very inflamed. It looks infected. Immediately got on the phone, got her in to see the doctor. And in fact, the person had a very, very infected wound site, so needed to go back in the hospital. So that versus 42% of the individuals who chose not to be in our program were back in the hospital within 30 days. So this is starting to show what a program like this can do.
And the cost effectiveness.
And the cost effectiveness of it. And it's working within the community because we work with the diabetes coalitions out there when we do training. And what we've actually started to institute after that is for our follow-up for our folks is Keisha does provide chronic disease management courses to the community out there as well. One of the things we should also say here is when we're providing education not only to the individual, but also to their family, because their family is usually at the same risk as they are from many of these conditions. And we also know that if you're going to change behavior, you have to change behavior of the entire unit. Because if we teach somebody you need to eat better, but everyone else is cooking everything in lard, it's not going to change. But can we do this better? Absolutely. And in fact, this is the grant I'm currently writing that will go out in February, is how do we take this the next step for the education side of it? How do we change our education so they understand it quicker, more thoroughly? And how do we really assess whether they got it or not? And then can we get it from knowledge acquisition to transfer to actual changes in behavior? So that is the next level of what we're trying to work with the community to really move the needle on. Okay. One of the fun kind of offshoots to what we've done is we've developed the only stroke survivor and caregiver support group out in Eastern Kentucky. It's been going since July of last year. We meet every single month. It's the last Wednesday of every month. And that's my team up there. We did an updated one Wednesday night while I was down there. We had our second annual holiday potluck. Everyone did their very best to make sure everything was healthy-ish.
I'm sure.
Yeah, except we have one of our people is an amazing cook. So I felt I had to eat her stuff. So, but having a support group as that follow-up we're finding is such a key thing. And in fact, I wish I could put it on. After Wednesday night, one of our families actually posted on Facebook how important it was to have this support group, because it allows them to grow as a community. It provides us a forum where every month they determine what education they want to hear, and we bring in the outside person to provide the education. By having it usually either at the Center for Excellence in Rural Health, which is literally 100 feet from ARH hazard, or at ARH Hazard, one of the things that has been nice is while we're meeting, we have people coming down from the stroke floor. Either the patients or the caregivers can come down and can see the community of people who are on the other side of the journey. So it gives them hope, gives them a better sense of what to start to look forward to. And trust me, our people are pretty unfiltered. They'll lay it out, the realities of the world, but they're also really bonded as the ultimate group. But it then, once again, provides you the opportunity to get back in there to provide the follow-up education. This is how we have found people for our new PCORI grant, because they trust us. Because everything we do has some sort of service or resource goes back to the community. Okay. So, like I said, it originally started off as a grant through the Center for Excellence, or the Center for Translational Research here, but now it's a service program. So it's co-funded through ARH Hazard, the Center for Excellence in Rural Health, and the College of Health Sciences. But we're in that really interesting and precarious area where everyone loves our program, but no one's ponying up and giving us funding for it. So this one is a little harder and causes me some sleepless nights to move it forward, because we know exactly what we're doing and we know the impact we're having, but we're building up and looking through and finding the partnerships to allow us to go through. And that's part of what I was meeting with the different hospital systems too, because guess what? We're saving them money. We're part of their care transitions team. It's a win-win situation. Okay. And we actually had our very first article out of this group, was just published 2 weeks ago to really show the effectiveness of this group. Okay. So that's looking at providing the resources in the area of education, in the area of services. Another program that Walt Bauer here was intimately involved with growing over the years was what we call Project CARAT. How many people have heard of Project CARAT? Okay, cool. Hopefully everyone's using it. Is a coordinating and assisting the reuse of assistive technology. Okay, what is it? This is a program in which we bring in used durable medical equipment of all makes and models and assistive technology. We clean it, we refurbish it, and we get it back out to people free of charge. So we bring in walkers, we bring in wheelchairs, we bring in power chairs, we bring in hospital beds. Pretty much you name it. The other big area that Walt was really involved with is a lot of hearing aids and different equipment coming in. We clean it, we fix it, get it back out, and to help the people. Because while we have a lot of individuals who have insurance, they can't afford the copay. So $10 copay to get them the walker, they can't afford. Literally, I have quite a few people on our caseload right now for KC3T where $10 is a significant amount of their monthly income. It's our reality.
And then Medicare and Medicaid have cut back on what they'll pay for the durable medical equipment anyway.
Yeah, because bath benches is a luxury.
Yeah, you're not allowed, that's.
So I wrote a grant last year to another foundation specifically to buy bath benches, and we were able to
get
purchase 71 bath benches plus handrails that we could not keep them in stock. The moment I got them out to the sites, they were out the door. So I got to write another grant for more of those. But that's another way we can partner. We have the expertise in writing grants. The community has the need, so we can provide those kind of resources too. So the CARAT centers, the initial ones, this started off as a partnership with the State Office of Voc Rehab, the Carl D. Perkins Vocational Training Center, and it was a HRSA grant. So this started off as a grant 3.5 years ago. Of, okay, can we improve quality of life if we can develop these kind of resource centers? Okay, since then it has now come under the umbrella of the CATS network, so the Kentucky Assistive Technology Services Network now kind of oversees it. We went from our 2 sites in Hazard, Kentucky and in Thelma, so the Carl D. Perkins, to now we have 5 sites. So we now have one in Louisville. Associated with Spalding University. We have one out in Paducah, associated with Lourdes Hospital, and then we have one out in Murray associated with the Center for Independent Living or Assistive Living. So so we have 5 sites across Kentucky. The one area that we have a huge hole right here in Fayette County. We did have a partner here that we are now trying to work with again to oversee the areas. But the first 2 sites in Hazard and Carl D. Perkins, we started the one in Hazard because part of the University of Kentucky's physical therapy program is actually based in Hazard at the Center for Excellence. So we have 3 different years of students, 18 students per year based in Hazard. So I have a workforce down there. So I turned this into a service learning program. So it's actually the students who run the site. They are in charge of it. So they have to keep track of the inventory coming in. They clean it, they fix it. We give lots of training to them, but they have completely bought into it. And they are very happy with how much they're able to provide services. Being a PT, I mean, when I used to do home health, I was always fixing wheelchairs. I mean, it's a skill set you need to have as a PT. I mean, I was always MacGyvering something, as Tony laughs. You always MacGyver some sort of wheelchair and that. So I go, do you know what? It's a good skill set for my students. Teaches them to truly understand equipment, and it allows them to provide back to the community. They love it.